Yeah, survivorship issues are always really tricky because what we mean by survivorship can be quite heterogeneous, or sometimes we're using the term in different ways from person to person, or even sort of imprecise ways. So, what I would start with is to say when I hear survivorship and talk about survivorship, I favor the broader definitions that are used in some of the more recent guidelines that basically say survivorship begins at cancer diagnosis. That does make it a bit trickier to answer your question, though, because with a disease like AML, there's an incredible amount of heterogeneity in what happens to these patients and their families and their caregivers within the first few days, weeks, months, and then years after diagnosis. And unfortunately, not everyone gets to a point of more sort of chronic cancer survivorship where there may be on maintenance kinds of therapies, or maybe in an active surveillance phase where they're coming in less frequently, feeling and doing well, maybe even getting back to work or doing other things, and maybe among the proportion of AML patients who are cured from their primary therapy, whether that be just a high-dose chemotherapy or maybe even with something like a consolidative stem cell transplant. So you can hear there, even in just those little bit of treatment paths that I've kind of alluded to and not described in much detail, that there's a lot of variability right there. One of the more challenging aspects of survivorship in AML is what we do to help patients feel better while they're going through really difficult treatments. So if you go back to the study that I described a moment ago, when we randomized patients getting high-dose chemotherapy to get the added support of integrated specialist palliative care, really that intervention is focused a lot more on helping those patients cope with the difficulties of being stuck in the hospital for a month and dealing with the challenges of the side effects and the other challenges psychologically that go along with being held hostage there in the hospital and by this illness, but also being sort of pummeled by all of these side effects of high-dose chemotherapy. And we see similar issues in patients who get stem cell transplantation. If it's allogeneic transplant, where we often are using high-dose chemotherapy and other sort of difficult preparative regimens to prepare that person to receive and benefit from the allograft, those can cause a lot of symptoms and other toxicities. And we found in other studies that my colleague, Dr. El-Jawari, has led and published, some of which are still ongoing too, that those patients as well benefit from that added extra layer of support of integrated specialist palliative care to help them deal with some of these symptoms and side effects, and also with coping and uncertainty kinds of issues around psychological distress, and not sort of knowing what the outcome may be, but knowing you're going through something really, really difficult and hoping that you will come through the other side where it will be worthwhile in the end to have gone through that. And maybe that gives you the chance at long-term cure. So there's that one phase of treatment that's the sort of early, upfront, more intensive phase of either high-dose chemotherapy or even maybe transplant as a consolidative therapy. But now we have this new paradigm of AML treatments where some patients are receiving lower intensity therapies. So we're increasingly using things like venetoclax plus low-dose chemotherapy, or even single agent targeted therapies. We've got a couple FDA-approved FLT3 inhibitors, a couple of IDH inhibitors. These are used sometimes frontline, sometimes in relapse refractory patients, sometimes as single agents, sometimes as combination chemotherapies and with targeted therapies. And we don't know that much about the patient experience of these treatments, but we do know that they are largely not curative treatments. And so now we are starting to see in some of these patients a really new, exciting, but still difficult issue where there may be a bit more of that kind of chronic cancer survivorship, where a patient may receive, say, a hypomethylating chemotherapy plus a targeted therapy, a venetoclax or something else, go into remission within a couple months, but not probably be cured, and have to stay on that treatment indefinitely until either they can't stand it and tolerate it anymore, or they want to come off of it, or it stops working. And sometimes that can be months or even a few years later. So how do we better support those patients and families through the side effects, through the back and forth of coming to the clinic, sometimes being in and out of the hospital, the financial toxicity that can come along with these treatments, and sometimes the sort of just cumulative side effect profile, sort of like what we are seeing in multiple myeloma, where patients may get 5 or 6 sequential lines of therapies over 5 or 10 years and have these sort of cumulative toxicities. How do we better support those patients and families through this different kind of stage of chronic cancer survivorship? AML still isn't quite there. It's unfortunately much more acute and serious of an issue in terms of 5-year survival rates and earlier, more severe relapses and refractory disease, and with fewer new therapies available. But so many new things are coming online now that I think we are moving towards a phase where survivorship in AML may look quite different in the coming years. And so it's not just these high-dose chemo patients and getting to transplant or not and supporting them through survivorship after they hopefully complete therapy and maybe end up being cured and maybe not, maybe face a relapse. Now we have these sort of low-intensity chronic cancer treatment kinds of patients as well, where we're all sort of learning together how to better support them and juggle these new different treatments and figure out what's the right one to use when for which patient and scenario.